So, if you are ready to relax, or ready to learn, or do a bit of both, please do put some headphones in, sit back, relax, and join me on this revision session. So, for some context, I am a qualified doctor working in the UK. I have been for the past year or so, and in theory, in about 4 or 5 months, there's an exam that I might be taking. I might actually be delaying it by a year. But in theory, I have an exam coming up in about 4 months' time, and I need to revise for it. Don't we all have an exam to revise for? So a really good resource. There's many fantastic resources out there, and this is not a sponsor. Although if you would like to sponsor me, Past Medicine, please do contact me. That would be a cool one. I'd like to get a free subscription to this. But Past Medicine, let me pull it up, is a really fantastic resource for medical students and doctors alike. If you are a medical student, you absolutely 100% know about Past Medicine. But I've downloaded the MSRA, which is the name of the exam. Strangely close in name to MRSA, which I always thought was a bit odd. But the MSRA, which I think is like multi-specialty something exam, regional exam or something like that, I'm not sure. I want to be a GP, 100% set on being a GP, and this is an exam you need to do really well in if you want to get somewhere kind of high demand like London, which is where I want to move back to. So I'm going to start revising as early as I can, taking plenty of like holiday and things like that, annual leave to revise for it. And at the moment I'm averaging like 40 to 50% on these questions, which is not great, which is why we're revising. We have to start somewhere. So I've also got my whiteboard with me with some other colourful pen options. I might kind of do diagrams. I'm a bit of a visual learner. Apparently the whole like visual or auditory learner kind of stuff is all just complete bollocks, but apparently we're all just like equal parts of all of them. But that being said, I do like to draw, so I will be using the whiteboard. Hopefully that will be a satisfying thing for you guys to watch and enjoy. Hopefully it will help you understand as well. But yeah, sit back, relax, and let's start some questions. I'll also be kind of jumping over to Geeky Medics and some papers online. Zero to Finals is also pretty good, but by and large we'll be sticking to Past Medicine and their kind of blurb descriptions of things. So actually what I might do is slightly reduce this so we can make it ever so slightly bigger for you guys. Actually, I don't think we necessarily need to make that smaller. I don't think you guys need to see my computer setup. As you can see, I have my main computer here and my laptop here. I also have my iPad, which usually I have like ASMR playing while I'm revising, but yeah. Anyway, it's weird calling it revising when you're actually like working in a job, but I suppose it is an exam and you revise for exams. I usually call it learning rather than revising, because usually I didn't know any of the stuff to begin with. So anyway, let's start. I'm going to be kind of another preface before we really get into things. I'm going to be like really focusing on these questions, so I might try to explain things to you here and there, but by and large I'm just going to be doing the questions and monitor. Okay, fair enough. Yeah, I thought you would just switch to an ARB or something straight away, or a beta blocker or something. An increase in serum creatinine up to 30% from baseline. That is so annoying. It is literally on the borderline of 30%. That is so annoying. I didn't know that guideline. Things I always say is annoying, but it's not annoying because that's the whole point of doing it. I didn't know, and now I know. Whether I remember is a different question. Continue recheck at 3 months as per normal schedule. Serum creatinine is up to 30% of baseline acceptable. Okay, due to the risk of hypokalemia and raised creatinine. Claw, 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 claw. Fine. So side effects, blah 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 blah. We know all of this stuff. Renovascular disease. Okay, monitoring urea and electrolytes should be checked before treatment. Rising creatinine, potassium expected starting. Acceptable changes up to 30% from baseline. Increase of up to 5.5 of potassium. Okay. And this is just remind myself of this. So under 55 or type 2 diabetes. This is for hypertension, isn't it? Yeah. Start on an ACE inhibitor or an android or an ARB. If you're over 55 and no type 2 diabetes or of Black African or Afro-Caribbean ethnicity, you have to start with a calcium channel blocker. Step 2 is that plus that, or that plus the diuretic, and the alternative is the same for this group of people as well. So calcium channel, which they started with, plus the ACE inhibitor, or you basically do the reverse, so the calcium channel plus the thiazide. And then step 3 is to add them all together. This is all, so you would never have the ACE inhibitor and the ARV. If next step is if the potassium is fairly low, that you can add low dose spironolactone, because that's a potassium sparing, and therefore you would accumulate. If you have high potassium, then you can add an alpha or beta blocker. So that I said beta blocker earlier, didn't I? Which is actually just wrong. Probably because that's also rate control. Blood pressure is not controlled. Forward with their specialist review. Okay. 30-year-old woman. I'm going to actually be skipping over some questions as well. I mostly want to get the emergency medicine and like more kind of urgent GP ones, because I'm actually starting, or have started in theory, a placement in emergency medicine now. So I want to kind of read up on that stuff. 10 weeks pregnant presents to the early pregnancy unit. Dropping clinic. Let's move on. Because I can come back to these questions anyways, it's not a problem. I mean, look, with 2,500 questions, I think we'll be okay. 22-year-old man with a 3-week history of diarrhea. His bowels have not been right for the past few months. He frequently has to run to the toilet. There's urgency. These symptoms seem to be improving up until 3 weeks ago. Okay, for the past week he is also passing blood. Feeling of incomplete evacuation after going. Okay. He has lost no weight but has a good appetite. Examination of his abdomen demonstrated mild tenderness in the left lower quadrant, but no guarding was the most likely diagnosis. So, I mean, obviously you want to rule out, you're concerned about colon cancer, aren't you? But this seems slightly atypical for that. I think the urgency, the lost no weight, and even really, I mean, the tenderness is also a little bit uncommon. The blood is an issue, but this is most likely diagnosed shows that there's sort of like a relapse remission kind of thing going on. Effective diarrhea, it'd be weird for that to happen. Diverticulitis, I don't think it would do that either necessarily. Colon cancer, again improving in symptoms, then getting worse. Bit weird. Ulcerative colitis, passing some blood. I really do struggle. I think also the localized. Oh, which one is it? I can't remember. Ulcerative colitis, is that the skip lesions, or which one is limited to the colon? Because that would be your left lower quadrant, wouldn't it? So. I can't bloody remember. Ulcerative colitis, you definitely get bleeding, passing some blood in this. You do. Yeah. Okay. Thank God I got that. That'd be a bit embarrassing. Age symptoms, diarrhea, blood in the stool, left lower quadrant, chronic, blah blah blah. Less likely due to the patient's young age and lack of significant abdominal guarding. True, it'd be more effective, wouldn't it? Or like inflammatory pain. Less likely given the age, of course. Lack of weight loss, change in appetite. Blah 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 blah. Yeah. It could be a potential diagnosis. Non-bloody diarrhea. Yeah. Extra intestinal manifestations like oral ulcers or skin lesions. If diarrhea unlikely to change the duration of symptoms of highly improvement. 1 to 2 weeks without treatment. I do like to see people's comments. Oh, I've just realised that you guys can't see that on the screen. That's fine. Tenesmus, what's that? Rectal tenesmus. You guys can't really read this. Physical feeling that you have, that you need to have a bowel movement. Even though you just had one, and you know your colon is empty. Fair enough. Endoscopy, palsy, red raw mucosa, no inflammation. Pseudopolyps, widespread ulceration. Okay, Crohn's and ulcerative colitis. Here we go, this is pretty good. Crohn's has the skip lesions, mouth to anus. Lovely. Inflammation on all layers. No inflammation beyond the submucosa. Okay. So ulcerative colitis is specific to that area. That was my kind of query. Needed reminding on that. Okie dokie. Let's move. Well, let's see these then. So we've got abdominal X-ray of a patient with ulcerative colitis showing lead pipe appearances of the colon. That's like the transverse. Ankylosis of the left sacroiliac joint. Bloody hell, I can't see that. Partial ankylosis of the right. This is the lead pipe. And lead pipe. Okay, and this one is showing barium enema. Patient with ulcerative colitis, the whole colon is affected by an irregular mucosa with loss of normal haustral markings. Okay, that's fine. Let's move on. 27-year-old woman admitted after developing dyspnea associated with pleuritic chest pain. A D-dimer is taken on admission, elevated activated. Subsequent CTPA shows PE. Past medication including giving birth to a son at 12 months ago. Anxiety. Two deep pain memories in the last 10 years. I don't know if that is like what sort of relevance familial history of DVT has on your own risk. Which of the following is most likely underlying cause? What? I'm confused. What's the cause of her pulmonary embolism? It's hard to say, isn't it, really? Well, I don't think antiphospholipid, because she gave birth 12 months ago, and that is like just very unlikely. Because it basically like guarantees you almost always have miscarriages. I don't really know the rest. I know factor 5 Leiden. That's the only one I really know. The other ones I don't really know very well. Okay, that's just complete luck. I mean, that's the only one I knew. So yeah, we'll have to go through these. I mean, I don't really know if I'm going to stick around to review this stuff for too long, because in ED I would get this per patient and that would be going to the medics. So activated protein C resistance factor 5 Leiden is the most common inherited thrombophilia. Fine, good to know. Unprovoked venous thromboembolism. Recommend testing for thrombophilia. Understandable. I guess that's where that was helpful, because it's the most likely underlying cause, and it's the only one I knew. Probably because it's the most common. It's not going to be antiphospholipid. The reason is because she had a full-term delivery only 12 months ago. Pretty good going for someone with antiphospholipid syndrome. It actually doesn't even explain that here, which is quite surprising. Past medical history. And so in the comments, okay, here we go. This is an interesting learning point. I wonder if they're going to talk about it in the comments. I'll just bring this over for you guys to be able to see. Someone else asked, could anyone explain why factor 5 Leiden, don't know how you pronounce this, is more likely than antiphospholipid syndrome? Okay, so I didn't know this. This is clearly the more reason, or the more pertinent reason. Antiphospholipid syndrome is acquired, not inherited. I didn't know that. The positive family history points towards inherited thrombophilia, of which factor 5 is the most common. Okay. It also says this was my rationale, because I didn't know. I thought antiphospholipid was inherited. She had a normal pregnancy and no history of miscarriages, which makes antiphospholipid syndrome less likely. Cool. I have to admit, I quite like when, if I got this wrong, I wouldn't have been too bothered, because it's like, what can I take away? You know, what was my clinical reasoning? And my clinical reasoning was, like, I would definitely never diagnose someone with factor 5 Leiden. I couldn't, but let's say that I had the ability to, I wouldn't, would I? I could pretty damn sure say that they don't have that, which is helpful. And here we go, presents to the emergency department. 45-year-old man presents with a 4-hour history of left eye pain associated with headache and blurred vision. No history of trauma or previous eye disease. Eyes watering with erythematous conjunctiva. Oh, I hate ophthalmology questions. His right pupil is reactive, but his left pupil remains dilated and unresponsive to light stimulus. Oh, for God's sake. Not conjunctivitis. I don't actually really know what keratitis is. I think it's one of these two. Scleritis, I don't know if you... Oh, I just don't find it super dull. It's not a good excuse. Fixed dilated pupil. I thought anterior uveitis incorrect. Characterized by symptoms of painful red eye with photophobia. In contrast to a fixed dilated pupil, anterior associated with a constricted pupil. Fair enough. I was just wrong. Patients with a history of HLA-B27 positivity or autoimmune conditions are more likely to develop anterior uveitis. This is also, let me just remind myself, I'm going to open a separate page for myself. It's also associated with ankylosing spondylitis. Yeah, that was it. Juvenile arthritis, uveitis, psoriasis, and inflammatory bowel disease and reactive arthritis. Okay, there's a huge selection of sort of rheumatological involvement with that. Acute closed angle glaucoma, unilateral eye pain, headache, and that's where you get a dilated pupil. Acute closed angle glaucoma gives you a blind pupil. Anterior uveitis gives you a constricted one. Annoying because most people got that as well. I should have got it really. Keratitis, the microbial invasion of the cornea causing eye redness. Photophobia and increased lacrimation. Eyelid edema, okay, that's a distinguishing factor. Ocular trauma, contact lens use. Topical eye drops, topical antibiotic eye drops. So this is infective and scleritis, inflammation of episclera, scleral and scleral tissues associated with systemic autoimmune disease in women, mostly. Eye pain, on palpation of the globe, ocular erythema, blurred vision, photophobia, increased lacrimation. Do you see my issue with ophthalmology? Okay, so acute angle glaucoma, yeah, it's due to increased intraocular pressure. There's a raise in the intraocular pressure secondary to an impairment of aqueous outflow. Hypermetropia, long-sightedness. These are predisposing pupil dilatation and lens growth with age. Severe pain, maybe ocular or headache. Halos around. As you can see, how many times I've got this wrong. Got another one wrong here as well. Hard red eye, corneal edema, nausea, vomiting, and abdo pain. Management: eye drops, a direct parasympathomimetic, something that mimics parasympathetic activation, I guess. Pilocarpine. Contraction of the ciliary muscle, opening the trabecular meshwork, increasing the outflow of aqueous humour. So I don't know what that would be though. Beta blocker timolol is often used. Alpha 2 agonists of apraclonidine. Pilocarpine. That's the one. Okay. Intravenous acetazolamide reduces aqueous secretions. Okay. Definitive management is laser peripheral iridotomy. Create a tiny hole in the peripheral iris. Okay. I hate ophthalmology. Mother comes to surgery with a 6-year-old son during the MMR scare. She decided not to have her son immunised. Okay. I won't be dealing with pediatrics, but let's go over it. However, Due to recent measles outbreak, she asks if he can still receive the MMR. What's most appropriate action at 6 years old? MMR. I don't know. MMR. You cannot vaccinate at this age as a live vaccine. Again, this is just like guidelines. I don't know. A range for measles and immunoglobulin to be given. Is that a different thing? I don't know. I guess so. Why could you not vaccinate? Cannot vaccinate. Why? I don't know. I'm just going to say that that's not true. It could be true for something I'm not aware of. Like why could you not? Why can you not give a live vaccine to an older child rather than a baby? Separate measles vaccine. Well, I don't know. Repeat dose in 3 months with a repeat dose. I think MRI is 1 dose. Boring. Okay. The Green Book recommends allowing 3 months between doses to maximise response rate. A period of 1 month is considered adequate if the child is greater than 10 years old. In an urgent situation, e.g. an outbreak, then a shorter period of 1 month can be used in younger children. You receive 2 doses. Okay, didn't know that before primary school. Occurs at 12 to 15 and 3 to 4 years. 12 to 15 months. Contraindications: severely immunocompromised, allergy to neomycin. Who receives another live vaccine within 4 weeks? Pregnancy should be avoided for 1 month. Immunoglobulin therapy within the past 3 months. Adverse effects: malaise, fever, blah blah blah. Just reading the comments. Just so I've understood correctly. If under 10 years, MMR doses 3 months apart, but can be given 1 month apart during an outbreak. If over 10 years old, doses given 1 month apart. Okay, I understand. So because he is under 10, it can't be given a month apart. It needs to be slightly longer. I.e. 3. But in an urgent situation, you can give it 1 month apart. Oh dear Lord, that's a horrible picture, isn't it? Man presents feeling generally unwell. Around 5 days ago, he started having a sore throat associated with. I have no idea what this is, by the way. Associated with myalgia and lethargy. Yesterday, he developed a fever. I'm not reading this properly. He started having a sore throat associated with myalgia and lethargy. Yesterday, he developed a fever. Over the course of the past period, his past medical history includes anxiety, atopic eczema, widespread erythematous rash, with many of the lesions having a target appearance. Some of the lesions are becoming bullous. His pulse is normal. No, it's not. His pulse is raised. He has a high temperature. So 5-day history of a sore throat associated with myalgia lethargy. Developed a fever over the course of the last 24 hours. Rash has appeared. Eczema. Anxiety can increase your immunosuppression, basically. 2 as well. Widespread erythematous rash with many lesions having a target appearance. Bullous lesions. I don't really know what bullous means, truthfully. There's conjunctivitis and some ulceration and sloughing around the mouth. God, that's disgraceful. Necrotizing fasciitis. I tell you what, it could be that. Impetigo. I don't think it's that horrible. Erythema multiforme major. I don't. It doesn't look like erythema multiforme, but major. I don't know what that is. Eczema, hepatism. I mean, it's a very quick onset for. I don't know what that is. Let's just go necro. I don't know. Okay, correct answer is erythematous multiforme major, of course. erythematous multiform. Yeah, this is what I associate with erythematous multiform. I guess they are target lesions, but major is a more severe form associated with mucosal involvement. Okay, I hate you. Let's just go over multiform. So target lesions seen on the back and hands before spreading to torso, upper limbs, pruritus, herpes simplex virus is a cause. Bacterial mycoplasma or streptococcus. Drugs can cause it, various things. SLE or connective tissue diseases, sarcoidosis, malignancy. Okie dokie. Fine. A 76-year-old woman presents with postmenopausal bleeding. Postmenopausal bleeding is always endometrial cancer until proven otherwise, I think. She's diagnosed with a well-differentiated adenocarcinoma and endometrium. Okay, fine. I was hoping that would be the answer, but whatever. There is no evidence of metastatic disease. What is the most appropriate treatment? Don't know. You'd have to ask an oncologist. A 76-year-old woman. I mean, we don't know her. We don't know like what her state is. Presumably she's like fit for surgery, but well, yes, presumably because 3 of these are. Prevera. Don't know what that really is or when you would give it. I mean, I feel like if you're going to do a total abdominal hysterectomy, you may as well. The thing is, I can't remember. I mean, she's postmenopausal, so surely you could take out these as well. Surely. So don't know what that is. That doesn't seem good enough. Let's go with that. Why not take out the things as well? Stage. Okay, so this is the treatment of option. This is the treatment of choice for stage 1 and stage 2. Prevera is a progesterone used as a hormonal treatment for endometrial carcinoma. It acts by slowing the growth of malignant cells. Wertheim's radical hysterectomy includes the removal of lymph nodes and is used to treat stage 2B and further on. Okay, so that's actually a more like a. Oh, it's radical. It's more. We understand that. Okay. Okay. Risk factors: excess estrogen, nulliparity, early menarche, late menopause, unopposed estrogen, obesity, diabetes, polycystic ovarian syndrome, tamoxifen. Okay. Protective smoking, yeah. I remember this one. Good to know, because actually I thought that it was protective of ovarian cancer. Okay. My hearing just went all weird. All women over 55 who present with postmenopausal bleeding should be referred on the cancer pathway. First line investigation is a transvaginal ultrasound. Normal thickness is a high negative predictive value. Hysteroscopy. Hysteroscopy, don't know how you pronounce that. With a biopsy is the next line. Management, you should always go for surgery if they are capable of having it. So localized disease is treated with total abdominal hysterectomy and the removal of the ovaries and the salpingo. I can't remember what they're bloody called. Oh my god, wow, hang on. anatomy. What are they called? The fallopian tubes. Oh my god, what is wrong with me? High-risk disease may have post-operative radiotherapy and progesterone therapy, which is Provera, used in frail elderly women who are not suitable for surgery. Asked review of potassium results whilst on call. Okay, that's high, but not mad high. Definitely high though. In fact, actually, it's quite high. That is quite high. I don't like that. You're unsure whether to give calcium gluconate, so you can use its own. She asks you to only give calcium gluconate if there are ECG changes. Which of the following ECG changes most consistent with hyperkalemia? Wow, I didn't see what I thought I would see. T-wave inversion. I mean, dual-tented T-waves is actually what I was hoping to see there. Prolonged QT interval, widening of the QRS complex. Peaked P waves, no. U waves, I can't remember what we're looking for there. Shit. Widening of the QRS complex. So what is going on at a pathophysiological level? At the cellular level, really. Okay, so QRS is the depolarization of the ventricle. T-wave is repolarization. I think that you get T-wave inversion, as you see that typically in like N-STEMIs, like preceding like cardiac events, widening of the QRS complex. Why would you see widening? Why would it widen in the same way that you get tau-tented T waves? I don't understand that. T wave inversion seems like the opposite of tau-tented T waves, though. It's going to be like prolonged QT interval, isn't it? I guess it could be. I guess that would make sense. Because it's taking longer to repolarize. Does that make sense? I don't know. Yeah, someone literally just said this. It's all done to T waves. Bastards. I hate these people. They do it on purpose, I'm sure of it. Not typically associated with hyperkalemia, instead it's more common to be seen in conditions such as myocardial infarction or ischemia. Widening of the QRS, hyperkalemia defined as serum potassium greater than 5.5. Most consistent and life-threatening change is widening of the QRS complex. Delayed ventricular depolarization due to impaired sodium conductance across cell membranes. Okay. I tried to reason myself into an answer between those three, but it was between these two because that one wouldn't have made any sense. ECG changes in hyperkalemia tau-tented T waves, small P waves, widen QRS, leading to sinusoidal pattern and asystole. Okay, fine. I hate you very much. And we are still below 40%. 35-year-old man presents with visual problems. Oh god, here we go again. He's had poor vision in the dark for a long time. Is now worried it's developing tunnel vision. Long time. Poor vision in the dark. Needs more carrots. Is that a thing? Diagnose. Prescribe him with carrots. States his grandfather has a similar problem. Was read blind as 50s. What's the most likely diagnosis? Oh my god. I have no idea. I have absolutely no idea. No, we're not doing this. I refuse to answer ophthalmology when I don't care about it right now. I'll let that destroy my marks later. For now, I'm skipping that question in favour of my mental health. What a weakling. Okay, a 69-year-old gentleman. I'll be honest, to not be like a complete wuss, the reason I'm skipping that genuinely is because I can't be bothered to answer it and then very quickly go through the ophthalmological explanation, which I don't have the energy to involve myself in the moment because it's not relevant for me. I will get that question wrong when I come back to it in a few months. 35-year-old man presented the visual problems. It's the same one. 69-year-old gentleman presents the emergency department. Here we go with sudden sided numbness with no other symptoms. He has a background of poorly controlled hypertension and diabetes. Head CT is arranged with no hemorrhage or mass. Diagnosed of having a lacuna stroke. Which part of the brain would be affected? A lacuna stroke. Lacuna matata. Don't remember. I think lacuna. Genuinely can't remember. Is it related to... I mean, you'd expect to have some kind of ophthalmological involvement there. Cerebella, you'd think you maybe would have some sort of coordination issues. Basilar artery. Sorry, I got itchy nose. Thalamus, internal capsule, basal ganglia. I keep getting it, I'm like right on the edge of getting it correct. Everyone knows those 77%. Jesus. Common sites of lacuna strokes at the basal ganglia, thalamus, and internal capsule. Is affected by amaurosis fugax. Is affected by locked-in syndrome. Affected by Wallenberg. Oh, so this is... Okay, yeah, of course, another very weird ophthalmological disease. This is locked-in syndrome. Wallenberg syndrome and lateral pontine syndrome. Not sure I'll remember those. Fine, okay, so that is the basal ganglia, thalamus, and internal capsule. We'll just move on from this. Which of the following is associated with a good prognosis of rheumatoid arthritis? Wait, hang on. Okay, whatever. Good prognosis. I mean, I don't need to know this either, but we'll have a look at it. Which of the following is associated with a good prognosis of rheumatoid arthritis? Surely. I can't be insidious answer, surely. Anti-CCP. What, having them? Why would these be associated with good prognosis? HLA-DR4. I don't know what that is. I mean, yeah. It surely has to be as incorrect. Susceptibility rather than this is weird because these are all like weird. RA prognostic fact features. RF positive. Anti-CCP. Poor functional status of presentation. X-ray. Early erosions. Extra articular features such as nodules. works, it works. Okay. We've broken 40%, good for us. Limb problems. Okay, well this will be quite helpful. Select the best management option for the following clinical scenarios. A 65-year-old female presents with neck pain. Neck pain, loss of dexterity in both hands. Has been struggling to type at work using her mobile phone. Her symptoms have been deteriorating gradually over the preceding months. Oh god. Okay. I mean, neck pain, you give her a corticosteroid injection to the shoulder, unlikely. X-ray of cervical spine, that's a pretty good one. Spinal surgery, physiotherapy, could be lifestyle modification, could be that as well, loss of dexterity in both. That's like work, this sounds like work related stuff, so possibly lifestyle modification. Let's put that for now. 32 review 1% 3 days order sensation of her left foot and right forearm. Weird. She has an episode of visual blurring in her right eye a few months ago, which was solved after a few days. Altered sensation of her left foot and right forearm. Brief reflexes. That's weird, isn't it? That really is strange. Refer to neurology. Maybe a bit early. Didn't know though, that's weird. Resolved after a few days. I mean, could it be MS? I don't know, would you refer to neurology for MS? Bit weird though to be having that. That's kind of strange onset though. 45% of the stiffness and pain in her left shoulder, which started around a month ago. She had a similar episode that resolved by itself. Global restriction of shoulder movement, external rotation. Oh, I've forgotten the name of that thing as well. I mean, maybe corticosteroid injection to the shoulder then, or physiotherapy maybe is a good place to start. So we go with these. I'm not really sure, to be honest. Whoops. That's not a good sign, is it? Okay, let's have a look though. Okay. Why is this refer degenerative cervical myopathy? Is that what's going on? Most likely has multiple sclerosis. Visual loss, probably secondary to optic neuritis, a common ophthalmological association. Refer to neurology. 45-year-old female presents stiffness, blah blah blah. This is frozen shoulder, yeah. Global restriction, that's the name. I remember now. I remember seeing someone like this in GP as well. Shoulder movements. Yep, okay, that's fine. So, someone's actually said here, lifestyle modification and comorbidity optimization could easily be the answer for adhesive capsulitis. Oh, is that what? 65? Oh no, they're saying that for this one. For question 15. Just checking, you refer DCM to spinal surgery rather than neurology. This is spinal decompression. God, I've got that majorly wrong. Degenerative cervical myopathy. Pain in neck, upper lower limbs, loss of motor function, loss of sensory function, loss of autonomic features. Hoffman's sign is a reflex to assess for cervical myopathy by gently flicking a patient on the patient finger on the patient's hand. revealed disc degeneration and ligament hypertrophy. All patients should be referred for assessment by spinal services, so neurosurgery. Decompressor is the only effective treatment. Okay. 20-year-old hiker presents with fever. It's funny, someone describes themselves as what is a hiker? That sounds like a profession you'd only see in like a Pokemon game. Who would say, oh, I'm a hiker? 20-year-old hiker. Fever, arthralgia and red rash after being bitten by a tick. Okay, fine. You suspect, so he's got normal elevations and normal cardiovascular, so you suspect Lyme disease. I don't know what the treatment is. 14-day course of amoxicillin, 7 of ceftriaxone. I don't think you'd wait. This is a complete guessing game, so Lyme disease is pretty bad, so maybe not a 7-day course or something. Ceftriaxone could have been a good option, but maybe it needs to be longer. Maybe go with doxycycline. 21 days. Complete guesswork. Total guesswork. First line treatment for non-disseminated Lyme disease, a 21-day course of oral doxycycline. 50%. Hell yeah. Back up to absolute bang averageness. And sorry, I'm back. I went to the toilet, but I just realised the top part of the screen was cut off for a little while there, so sorry about that. But yeah, okay. So ceftriaxone is used in disseminated disease, which obviously this wasn't because he was doing pretty much fine systemically. Systemic features: headache, lethargy, fever, arthralgia. Very typical presentation. And look for Lyme disease, sort of bullseye appearance, bullseye rash. There you go. 1 to 4 weeks from initial bite, painless. Present in 80% of patients. Oh no, sorry, this thing is in 80% of Lyme disease, not tick bites. Heart block and mericarditis. Mericarditis. Peri/slash myocarditis. So pericarditis. You will see sort of like global ST elevation. So I assume this is showing as a heart block. Yeah, this is like that looks like complete heart block to me. Yeah, 3rd degree heart block with left bundle branch block. That the escape rhythm is from the right bundle. Yeesh, it's hard for me to be able to identify, to be honest. Sorry, there's quite a bit of noise outside. In the meantime, I skipped this ophthalmology question and got this question wrong about hyperlipidemia. Primary prevention is 20. Secondary prevention is 80. I went in the middle. Never sit on the fence. At least you can see where people put their money, at least. So this one, complicated revision of hip replacement. 8-year-old lady with 2 units of packed red cells. That's a lot of fluid to be putting into someone. Heart failure, bisoprolol, and all of these bits and pieces. I think you should be giving furosemide. Albumin, not sure what that would do other than just draw more fluid into the veins, into the vascular system. Platelet transfusion, don't think it's necessarily needed. Sertrazine, isn't that like an anti-inflammatory? I'm not really sure. I think furosemide. Okay, that was clearly more obvious than I realised. Just to prevent fluid overload. Sertrazine and hydrocortisone are used in cases of anaphylactic reaction to the transfusion. "34-year-old thyroid. Endocrinologist arranges nuclear scintigraphy. Don't really know that, which is reverse patchy uptake. Yeesh. Okay, it's not Hashimoto's. Iron deficiency, I think would possibly do the opposite. Solitary. So, okay, I mean, this is annoying because I don't really know. I think the toxic multinodular goiter, you'd present with a goiter, so I think that would be annoying for them not to show, because I don't know the relevance of this. Patchy uptake. Adenoma, surely you would also have a bit of a growth. I'm going to go graves. That is super annoying. What? I am pretty sure you would be able to distinguish that with an actual goiter itself. That is so annoying. Okay, I just don't know anything about scintigraphies. Fine. Wow, I'm actually more annoyed than I should be about that. That's really frustrating. I swear, a toxic multinodular goiter, you'd be at least expecting to see, like, some kind of presentation. I mean, bro, look at this. Oh, you can't even see it, but look at this. As if you wouldn't put that in your... You would be presenting with a goiter. I mean, you wouldn't put that in your stem. That is a little bit annoying. It did say just anxiety, weight loss, and feeling hot. That's so stupid. That is so stupid. Actually, I mean, does Graves' disease, does that also present with a goiter? I don't think it necessarily does. Oh, but I guess you do get the classic, like, sorry, my leg's itchy. This is the only angle I can get to my shin. Yeah, okay, fine, whatever. Moving on. Well, no, let's read it. Let's say toxic multinodular goiter. So it reveals patchy uptake. Okay. Treatment choices: radioiodine therapy. 74-year-old man attends the emergency department with his wife complaining of weakness in his right arm and leg, reduction in vision, dysphasia. Started half an hour ago. She phoned the ambulance immediately. Patient is sent for head CT. This excluded a stroke. He was subsequently sent for CT contrast angiogram showed occlusion of the proximal anterior circulation. Actually, this half an hour ago. Oh well, I don't know how long these are taking. I guess we have to assume they are occurring immediately. Damn. Okay. I didn't know you did thrombectomy as well. I know the time frame, but thrombolysis and thrombectomy. Physical removal of the blood clot performed under guidance, image guidance. This is considered if thrombectomy is not available. Okay. Maybe do thrombectomy alone if outside of 4.5 hours. Then aspirin and clopidogrel are both options for secondary prevention. Aspirin alone would not be adequate management. The acute setting, and clopidogrel is offered as a means of minimizing secondary recurrence. correct. Oh my god. Following a hip replacement, patients should avoid crossing their legs. Hip resurfacing is now the most common type of hip replacement performed in the UK. Surely it's still total hip replacement. Patients should be encouraged to avoid using walking sticks in weeks. Okay, I'm refusing to answer the ones that are not relevant to ED because I accept this, because I'm pretty sure I'm going to get that wrong, and again, I don't think I'm going to actually synthesize the answer. So when I go on to do my orthopedic rotation in next March time, or next April, then I will do them. I promise I'm not ignoring them just because I want to get a higher score. Although that is playing some role, I will admit. Trust me, I'm getting the emergency departments wrong as well, so don't worry. Presented the ED with symptomatic menorrhagia. Within 2 minutes of commencing transfusion with 1 unit of red blood cells, she developed cessation of the transfusion. The assessing doctor suspects an acute hemolytic transfusion reaction, which is later confirmed by a direct Coombs test. What combination of symptoms have the women developed? I don't know if you necessarily get abdo-pain with a hemolytic transfusion reaction. Angioedema. I don't know about that either, to be honest. Hypoxia, fever, and hypertension. I feel like that is. Oh, you do get abdo-pain. Okie dokie, fair enough. Fever, abdo-pain, hypertension is hemolytic, acute hemolytic reaction. Blood transfusion complications, non-hemolytic febrile reaction. This would be good to know. Non-hemolytic fever, febrile reaction. Antibodies reacting to the white cell fragments in the blood product. Fever and chills. Mostly occurs with platelet transfusion. Stop or slow the transfusion. Paracetamol, monitor. Minor allergic reaction. Foreign plasma proteins. Pruritus and urticaria. Temporarily stop antihistamine, monitor. Anaphylaxis, of course, this is IgA deficiency. Who have anti-IgA antibodies. Hypertension, dyspnea, wheezing, angioedema. Stop the transfusion. IM adrenaline. A, B, C, D, E support. Acute hemolytic ABO incompatibility. Secondary to human error. Fever, abdominal pain, and hypertension. Stop. Confirm diagnosis. Check the identity of the patient name. Direct Coombs test. Repeat typing and cross matching. Fluid resuscitation. Transfer. Ayataka and tralase. Transfusion associated circulatory overload. Excessive rate of transfusion. Pre-existing heart failure. Pulmonary edema and hypertension. Stop or slow. Consider intravenous furosemide. A tralase transfusion related acute lung injury. Non-cardiogenic pulmonary edema. Thought to be secondary to increased vascular permeability caused by host neutrophils that become activated by substances I've forgotten. I've forgotten there was like some kind of condition which is like a taco or trally in which you get like hypotension, but to manage it you actually have to give furosemide, which is a little bit counterintuitive, like from like a very simplistic point of view, but I can't remember. It's fine though, let's move on. We're on 1 correct answer in the last 5, not looking good. Inpatient for duodenal ulcer. First metatarsal severely waking up this morning. So what they're saying is gout. I don't really know the like association with duodenal ulcers or whatever sort of. I mean, how do you treat that with an NSAID? So with an NSAID, what am I on about? It's a complete opposite thing. The duodenal is not gastric ulcer. I don't actually know. Maybe just gastroprotectors. I don't know if you give antibiotics. Yeah, actually, maybe a BPI does increase your risk of gout. I'm not sure. Allopurinol or colchicine. I'm pretty sure it's one of these. I mean, could be. I mean, diclofenac you're not going to give because of the duodenal ulcer. Maybe that's the point that they're trying to make. So, I mean, indomethacin is also an NSAID. Cyclazine is a antiemetic. I'm not sure about that. One you give like as sort of like prevention, and one you give as treatment. I can't remember. It might be colchicine you give as treatment. Allopurinol they take generally. Okay. Diclofenac and indomethacin are contraindicated because of the duodenal ulcer. Glad we got that. Colchicine is a suitable alternative. So these actually are given as initial treatment, but it was the duodenal ulcer which was the contraindication point there. Allopurinol should not given in the acute phase, but it's good for preventing recurrence. Okay, glad we got that. Colchicine is a good alternative to the NSAIDs. So the acute management you give NSAIDs, or if contraindicated, colchicine. Fine. Gastroprotection as well. Okay, interesting. Caused by chronic hyperuricemia. Of course. Oral steroids may be considered NSAIDs and colchicine are contraindicated. I don't know what contraindicates it though. Main side effect is diarrhea, okay. Caution with renal impairment, okay. Inhibits microtubule polymerization, blah blah, has a slower onset of reaction, so maybe very acute situation you want to be giving NSAIDs initially. Okay. I understand it. Oh, I see. Is it because if your NSAIDs are being given, you want to just give them with the gastroprotection? Okay. I think that's a reasonable point to make. The rest, not sure if I can be bothered. Allopurinol is the main thing. Second line agent, not tolerated, is febuxostat. No idea. Refractory cases, you can give uricase. Patient persistent symptomatic. Pegloticase, okay. Won't remember those, but yeah, just try to remember. Uricase and pegloticase are kind of like the third, fourth line things. No dysuria or frequency commonly. Pelvic floor. I think that might be where you start. Regular toileting. It's kind of an odd thing. Bladder. I think maybe that. Yeah. Okay, so I sense. I'm recording it the next day, said like a human. It's a bit late in the day, I've been doing quite a bit of work today, so maybe that's why I'm a bit frazzled. But I'm on question 20 of, I've done tons of work today to be honest, but I'm currently averaging like 55%, so doing okay, but let's just do a few more questions so I can finish this video out, I think, because I didn't do an outro on the last one. So, 81-year-old woman presents GP with leg ulcer, painless, which suggests it's venous, I think. On examination, superficial erythematous, oval-shaped ulcer superior to the medial malleolus ankle. I think that's normal. Hyperpigmentation. So because it's venous, I think. I don't think it's urgent. Maybe just erythematous. So maybe just nope. Again, I don't know these management things. Venus. Wow, that's the worst one. Inappropriate. Is inappropriate for cellulitis. Okay, so you just do compression bandaging for it. Usually 4 layers, then possibly oral pentoxifillin. Okay. Which one of the following X-ray changes is not associated with osteoarthritis? I don't think it's that. I think these are. Is rheumatoid arthritis decreased joint space? It's the first one I got rid of again. The worst possible answer. Loss. Yeah, loss of joint space. I'm all over the place. Osteophytes forming at the joint margin, subchondral sclerosis, and subchondral cysts, periarticular erosions. makes sense. Wait, myalgia. My brain is telling me to do ESR. I don't know why it was telling me to do that. I guess the ones are not particularly specific. Polymyalgia rheumatica. My brain was screaming temporal arthritis, even though there's no headache. I don't really know why it was telling me temporal arthritis. Is there some sort of like association between the two? That's what I was going. I'm speaking to ChatGPT. If you're wondering what I'm typing in. Polymyalgia rheumatica and temporal arthritis, also known as joint cell arthritis, are related inflammatory conditions that often occur together. So, yeah, I clearly had that going on, which is what made me say ESR, but not quite there. Glad I got it though, thankfully. So, someone's commented, why transient loss in vision in one eye? And someone said, polymyalgia rheumatica is associated with temporal arthritis, which can cause amaurosis fugax. Okay. I suppose that's the benefit of going over something like a billion times. Eventually, things do kind of stick in there, at least subconsciously. Overdosing and poisoning. A 50-year-old man who has dislocated her shoulder is accidentally given 10 milligrams rather than 1 milligram of diazepam. She stops breathing but still has cardiac output. Ethanol, I actually don't know. I don't know why some of these necessarily would mean. I really don't know. Flumanazole. I just can't even remember what flumanazole does. I don't know. I'm trying to go by, process of elimination, gastric lavage. Would you really do that now? I don't know what urinary alkalization is. Atropine. I guess I can see a theory where that would make sense. Hemodialysis. I think you need to do something a bit more emergent than that. Adrenaline, again, I can kind of see where that's going, but beta blockers. I mean, I'm not understanding that. Specific antibodies. Maybe there's something for it, but IV bicarbonate, I'm trying to think. Why? Unless it like is some sort of binding thing. You bought a cheap bottle of vodka from the market and drank it in 2 hours. It contains methanol. Is worried that she bought a cheap bottle of vodka from the market and drank it 2 hours ago. She has since heard over that it contains methanol and is now worried as she has a headache and feels dizzy. Sure, gastric lavage. Again, I'm not really too sure. 59-year-old man who takes deliberate overdose of 60-digoxin and he presents. I thought you give Digibind for digoxin. Is that what specific antibodies is? Is it called? Is that what Digibind is? I don't really know. Let's go with this. Okay, flumanazole. Process of elimination wins again. Yeah, I guess that's. I couldn't think of Digibind coming under any of these other ones. If they said Digibind, maybe they were too obvious for digoxin. It's probably the only reason I've remembered it, to be brutally honest. acetylcysteine NaC, activated charcoal in under an hour. Salicylate, so that's like your ibuprofen, isn't it? An aspirin. My God, it's been a long day, clearly. Aspirin, yeah. Anyway, that was a worry. Hemodialysis or urinary alkalization with IV bicarbonate. I don't actually know what urinary alkalization is. Opiates, naloxone, benzodiazepines, and flumazenil. Flumazenil. Minotic overdose, managed supportive care. Only due to the risk of seizures with flumazenil. When it's severe or iatrogenic overdose, tricyclic depressants, IV bicarbonate will reduce the risk of seizures and arrhythmias. Quinidine or flecainide for antiarrhythmics, contraindicated if they prolong the polarization. Amiodarone should be avoided in prolonged QT interval. Dialysis is effective, so just IV bicarbonate and then, I guess, whatever, lithium, normal saline in mild to moderate hemodialysis if severe. Sodium bicarb is sometimes used. Limited evidence. Warfarin, Vic-K and prothrombin complex. Heparin, protamine sulfate. Beta blockers, bradycardic atropine in resistant cases. Glucagon is used. I know that one. IV glucagon. Ethylene glycol. Ethanol has been used. Methanol poisoning. Ethanol or hemodialysis. Hyperbaric 100% oxygen. Cyanide is hydroxycobalamin. Okay, let's do one more and then we're going to stop recording. A 30-year-old patient presents the emergency department with a fever, headache and neck stiffness. Has a high fever, blood pressure is down, heart rate is high. Rolling over arms like a single base appropriate in the emergency department. Okay, so of course it's meningitis. I hate this. Well, if it's in the community, you give penicillin V. I don't think you actually do give acyclovir. Amoxicillin, I don't know about that. I know cefotaxime. I've not heard of these. I don't think you give a lumbar puncture now, it's a bit dangerous. CT head. I mean, the most immediate thing you're going to do surely is to give antibiotics, so thank God for that. These were confusing me. Amoxicillin may include cover listeria. Okay. Play an important role in, of course. Incorrect, but it's crucial for diagnosis of meningitis, which don't take priority. Biology should be delayed in the following circumstances: severe sepsis, rapidly evolving rash. Yeah. Cure. The 4-year-old woman presents due to development of a purpuric rash on the back replace that now. I don't know about HP. Oh my god. Wait, that is in the same ones. I know it's not per deciliter, so that's a... Why have they done that? That's so lame. So that is actually... That's why I was concerned, because if that's in the units that I'm usually working under, then that's just like you're dead. But that's actually normal. So she's got normal, I think, right? Times by 10 to get to litre. That's very lame that they've done that. Oh, why is that actually normal? Platelets are super low, but you only under 20 with signs of bleeding, or 10 and below with, you know, just irrespective, you do platelet replacement. Fabric rash, maybe that. I'm actually not sure. The Burberry rash is making me think Henok Schoenlen Purpura. I don't know anything about microgynon, so that would be a guess if I went with that. Antiphospholipid, I feel like there would be maybe more to it if we're going to go with that. Thrombotic thrombocytopenia. Would there not be more signs of clotting as well? The platelets though, let's go with this. Idiopathic thrombocytopenic Purpura. God, hematology as well gets me. Okay. Okay, let's leave it there. I think I averaged in the end maybe just below 50% or something overall, which is basically no improvement over the past month. Actually no, that is getting slightly better. I'll take it, it's fine. It's all about the learning. So guys, thank you for watching. If you like these types of videos, leave a like, subscribe if you're new. Thank you so much for watching. I'll see you all very, very soon.